Okay. Ladies and gentlemen, esteemed colleagues, good morning, good afternoon, good evening, good night, and welcome to this webinar, which I have a pleasure to chair today. So the topic of today's seminar is challenges and opportunities for primary cancer prevention. And to put this topic into context, we can ask ourselves two broad questions. What is the evidence? That is, how do we identify cancer-causing agents? What do we know about these agents? How many cancers are due to these agents? The other fundamental question is, what are the solutions? In other terms, how can we protect ourselves from these agents or otherwise protect ourselves from their effects? So from the World Cancer Report, on which this series of seminars are based, we have an overview of the answer to those two questions in the chapter 2, causes of cancer, including hazardous circumstances, and in chapter 5, preventing particular tumor types. So what is the evidence? Here at IARC, we have the series of monographs which are aimed at the identification of carcinogenic hazard to humans. And at this date, the monograph program has evaluated 121 agents that are carcinogenic group 1 and 90 agents that are probably carcinogenic to humans group 2A. What are the solutions? So in terms of prevention, there are three levels of prevention. Prevention can take place either before the disease onset, and that is meant as primary prevention, that is avoiding the development of a disease or removing the risk factor. Then we have level of secondary prevention, which consists of either early detection and treatment, which prevents the progression. If the prevention is made after the clinical diagnosis, this is called tertiary prevention, which reduces the complication of an estimated disease. Here at IARC, we are developing a series of handbooks of cancer prevention, which actually identify agents, interventions, or strategy that can prevent cancer, either in primary or in secondary prevention. What is the overall picture of the research to date? It's given in this poster here, and what you see in red is what is the evidence. What you see in green is what are the solutions. Unfortunately, there is today much more red than green on this poster. It means we have identified many more agents that cause cancer than actions to prevent those cancers. But now I want to introduce our two panelists of today, Professor David Hunter and Professor Bernard Stewart will give us an overview of how to answer to these questions. So first, I would like to introduce Professor David Hunter. David Hunter is the Richard Dahl Professor of Epidemiology and Medicine and Director of the Translational Epidemiology Unit at the Nuffield Department of Population Health in Oxford. In its presentation, David Hunter will review the scientific evidence about the role of a number of modifiable risk factors and protective factors in the incidence and the mortality from some of the most cancer types around the world, such as lung cancer, colorectal cancer, breast cancer, and cervical cancer. David, the floor is yours. And I'll stop share.
Thank you, Beatrice. Let me just bring up my slides. Terrific. Can you see my slides?
Yes.
Great.
Yes.
Fantastic. Well, thank you so much. And I'd like to thank Beatrice and her colleagues at IARC for the privilege of talking to you today. And I'm going to be talking about cancer trends. I'm going to be talking about how much of the burden of cancer is potentially preventable. Sometimes you hear the phrase, half of cancer is preventable. The question in mind is, are we talking cancer incidence or are we talking cancer mortality? Obviously, cancer mortality includes a big component of potential treatment. It's important to distinguish between what we know about cancer, the risk factors, all of those things in red that Beatrice showed us on that slide. And some of those are amenable to prevention. Risk factors can be withdrawn, and some of them cannot. So we talk about the difference between modifiable and non-modifiable risk factors. And I'll be concentrating today on what we know about modifiable risk factors. So the first thing to recognize is that the burden of cancer is increasing. It's estimated to about double over the next 50 years. And a big piece of this is just our success in increasing life expectancy around the world and the fact that the world's population is growing. So for pretty much any disease that is a function of age, the number of cases of that disease will increase if we're talking about a growing population. Unfortunately, much of that population growth, most of that population growth, is expected to appear in less developed countries, and the fastest growth is in the least developed countries. And so, of course, these are the countries that are less likely to have diagnostic and treatment facilities available to treat people if they are afflicted with cancer. And so cancer prevention becomes even more important in the global picture. In addition to population growth, and probably more so than population growth, around the world, we're dealing with aging populations. So 30 years ago, the population pyramids for countries like China and India, India, by the way, will be the biggest country in terms of numbers of people in the world in the next 10 years. So 30 years ago, we would have seen the classic population pyramid with lots of young people and very few old people. But as fertility rates have declined and life expectancy has increased, we now see this bulge of people living longer, which is a fabulous success for public health, but a problem when it comes to cancer, many cancers being associated with increases in incidence of cancer at older ages. So in China, partly due to the one-child policy, the modal age is going to be in the 60 to 70-year age group in 2050. And India is about 20 or 30 years behind, but rapidly a large proportion of the population is moving into middle and older age, the ages in which cancer is much more likely to be diagnosed. What cancers are we talking about? So these are estimates from IARC, showing the numbers of cases. This is not adjusted for population. This is just numbers of cases around the world between 2018 and 2070. And so the cancers that we usually associate with a more developed country spectrum, colorectal, breast, lung, prostate, become dominant on the global scene as life expectancies increase. And so these are the cancers that we have to look at to see whether we can find ways of preventing these cancers before they require treatment. And looking at this a different way, looking at countries according to the Human Development Index, which is essentially on the left here, the poorer countries, on the right, the richer countries. Much of the growth is going to be in absolute numbers in the very high Human Development Index countries. These are the countries that may be better prepared to treat these cancers, but there's a massive challenge. We all know that in most of the developed world, we strain to diagnose cancers early enough and treat them effectively. Many of the treatments are very expensive. So there's a massive challenge for the developed world as the cancer burden increases. But look on the left there, the challenge for the poorest countries, starting, fortunately, from a very low base. The numbers of cases are projected to increase by fourfold over 50 years. And so this is going to put even more stress on the impoverished health systems in those countries. So this is not, this is really a global phenomenon, but the impact is going to be different according to each country's ability to treat cancers, and the focus really needs to be on avenues of prevention, particularly in countries which will have a hard time keeping up with the caseload. And two of these big countries, again, dominate the scene in the middle there, China and India. And so those are special cases where cancer prevention is going to be very, very important if those countries are going to be able to cope with the epidemic of cancer. India in particular, again, most cancers diagnosed late, little access to treatment. So again, cancer prevention is going to be very, very important in those countries. And I put this all together. So basically in gray here, we've got the 2018 numbers ranked by Human Development Index, which again is a rough proxy for GDP and income. And in blue, the number of cases that we would expect over the next, by the end of the 50 years in 2070, purely as a function of demographic changes. So this is basically the growth of the population, the aging of the population, and across the world, the number of cases is expected to double. This is under a business as usual scenario where we're not successful in reducing these numbers through primary prevention. And so let me turn to the potential role of primary prevention in trying to mitigate this cancer pandemic. So the first thing to do is, again, just to distinguish between what we know as risk factors and what are modifiable risk factors. So this is the case of breast cancer, looking at the population attributable risks for breast cancer for postmenopausal breast cancer. This is a study based in a US cohort. And essentially, we know a lot about the risk factors for breast cancer. And down the bottom here, we estimate that about 70% of breast cancer can be attributed to established risk factors. But a lot of these risk factors are essentially non-modifiable. They could be in theory modifiable, but they're factors that in our social environment are unlikely to be changed due to a concern about cancer risk. So things like age of menarche, height, women don't make their decisions about when they have their first child, the number of children they have based on cancer risk, etc. The modifiable risk factors, weight change, obesity is a risk factor for postmenopausal breast cancer. Alcohol consumption is a risk factor. Low physical activity is a risk factor. Not breastfeeding or short durations of breastfeeding is a risk factor. Taking menopausal hormones is a risk factor. So these are the modifiable risk factors. And most estimates suggest that about half of the risk factors for breast cancer are potentially modifiable. So in theory, we could reduce postmenopausal breast cancer rates by about a third if women were able to avoid those modifiable risk factors. So that's a big chunk of a disease that we often think is minimally modifiable, but it requires very, very large changes in things that are difficult to change, such as weight, low physical activity, etc. And if we scale this up to the whole world, and I won't step through the evidence for all of these, but if we take estimates from the IARC database of how many cancers occur in the world, and then we apply the population attributable risks, so the proportion of each individual cancer that is thought to be due to a preventable cause. Smoking, of course, about 85% of lung cancer attributable to smoking. Infections, particularly in less developed countries, hepatitis B virus, hepatitis C virus, major causes of liver cancer, Helicobacter pylori, major cause of stomach cancer, human papillomavirus, perhaps the only cause of cervical cancer. And we have ways of either preventing these through vaccines or treating them. And so we can estimate if those vaccines and treatments were available to everybody and we could eliminate or close to eliminate these infectious causes, what that would do to cancer risk. Obesity, increasing evidence for certain types of cancer, the role of diet, extensively investigated by the World Cancer Research Foundation. Melanoma, about 90% is estimated due to ultraviolet exposure. Physical activity, there are estimates there. If we take all of these and we apply them to the incidence of cancer around the world, we can make a rough estimate of how much is potentially preventable. So here, top 27 types of organ-specific cancer and the numbers, dominated by lung and then breast and then colorectal. And let's just look at what would happen if we could wave a wand, easy for me to say, and theoretically remove the contribution due to tobacco. So that's in red. And so for lung cancer, an 85% reduction, but also reductions in other smoking-related cancers, such as esophageal cancer, liver cancer, laryngeal cancer, kidney cancer, a little piece of colorectal cancer. So we can step through this for all of the different causes sequentially and estimate how much, if we could remove these risk factors, how much of global cancer could be prevented. And to cut a long story short, if we could eliminate tobacco, we would probably remove about 20% of all cancers. If on top of that, not alone, but after we've removed tobacco, we could deal with those carcinogenic infections, that would drop the risk by about another 10%. Obesity makes a contribution, diet makes a contribution. Ultraviolet's really only causing one type of fatal cancer, melanoma, and so the contribution is relatively small. And sequentially, we get down to about 42% of cancers prevented. Again, if in the scenario where we could completely remove all of the risk factors for cancer. This doesn't account for other risk factors that are hard to quantify. Occupational cancer risks have been substantially eliminated in developed countries, but unfortunately, a lot of those industries or a lot of the way those occupational carcinogens are handled in developed countries still exposes workers to occupational risk. Air pollution causes some cancers. It's still a little controversial. Bernard will talk about some of the evidence there. And I haven't included any potential reductions due to screening. That's what Beatrice defined as secondary prevention. So obviously we could avoid a lot of cancers, for instance, colorectal cancer. If we had regular screening, people got either their adenomas or precancers removed so they didn't turn into cancers, or they got their early stage cancers removed before they were likely to be fatal. So that 40%, I think, is a sort of lower end of what is theoretically possible. A few limitations. We're talking sequential here, so we may underestimate the effects of those factors that came along later in the chain. So diet prevents some smoking-related cancers. So once we theoretically eliminate smoking, we're assigning less cancers prevented to diet. The latencies are substantial. So the one thing we know about cancer is there's often a 20, 30, 40-year gap between removing a risk factor and reducing risk back to background. And we still have weak evidence base for many things. So most of our information on diet comes from the analysis of diet in middle life and looking at the 10 or 20-year risk of cancer. A lot of nutritional epidemiologists think that childhood diet might be particularly important, but we've got very little evidence base on the role of early life diet and cancer 40 or 50 years later. It only applies to the top 27 cancer sites, but they do account for 92% of total incidence. Looking at literature, here are some estimates, all from developed countries, where people looked at, in their own country, how much cancer was theoretically preventable. And all of the estimates cluster around 30 to 60%, you know, that 40% figure. And mortality mainly varies with incidence, but there are slightly more cancer deaths preventable for some of the cancers that are hardest to treat and most likely to result in mortality despite treatment. So lung, liver, stomach. So in theory, we would prevent almost about 50% of cancer deaths if we could remove those major cancer risk factors around the world. Now, if there's any good news in this picture, it's that we really can make common cause with our colleagues in heart disease, stroke, diabetes, respiratory death prevention. WHO has the goal of reducing premature non-communicable disease mortality by 25%. And smoking causes, obviously, heart disease, stroke, obviously respiratory disease. Obesity causes a lot of these diseases, notably diabetes. So this really isn't only a cancer prevention initiative, a cancer prevention agenda. By doing these things, we'd also be preventing a lot of the other major causes of premature mortality. So in summary, smoking, common cause with the other diseases, obesity, ditto, infections mainly specific to cancer, but the good news is HPV immunization around the world is actually quite high. There's still concern, though, about maternal-child transmission, sometimes before the vaccines are able to be given. We've got fabulous news with hepatitis C, where new drugs can essentially eliminate that infection in about 12 weeks. We've got a vaccine that's highly protective against human papillomavirus, but still not available in much of the developed world. For ultraviolet, we're talking really about skin cancer-specific messages, occupation, and air pollution. So again, this is an agenda around the prevention of non-communicable diseases as well as specifically cancer prevention. So in summary, the burden's growing fast. Cancer is much more complex than most infectious diseases, CVD, and diabetes to treat. Each of the different cancers has different needs different diagnostic facilities. It needs different treatments, drugs, radiotherapy. Even with maximum prevention, many cancers will require treatment, and some of the greatest global inequities exist for cancer treatment. In many parts of the world, it's simply just not available. So we just need to keep our eye on the fact that a cancer prevented does not need to be treated, and prevention needs to be at the heart of national and global cancer control programs. With that, I will thank you and hand back to Beatrice.
Thank you very much, Professor Hunter, for this very interesting presentation about the proportion of preventable cancer. Very, very interesting presentation. I learned a lot. So we heard here about, I would say, theoretically preventable cancer. So call that, this is answering the opportunity side of the webinar. And now we'll hear maybe a little more about the challenges. And it's my pleasure to introduce Professor Bernard Stewart. Professor Bernard Stewart is appointed at the Faculty of Medicine and Health, University of New South Wales in Sydney, Australia. His research interests involve all aspects of cancer prevention, and he has contributed to the monographs program variously across the 100 volumes and has co-edited the World Cancer Report as published from 2003 to 2020. In his presentation, Dr. Stewart will discuss perspective in cancer prevention beyond the reduced exposure to carcinogens. Bernard, the floor is yours.
Thank you, Beatrice.
And stop the video.
I'll just go to screen to share. So we've heard from Professor Hunter about the modifiable risk factors being the key to cancer prevention, at least in the primary sense of cancer prevention. My contribution to this webinar is to examine, to some extent, the scope of modifiable risk factors that affect the incidence of cancer worldwide, and to look at the transition between modifiable risk factors on the one hand and achieving actual cancer prevention on the other hand. Crucial to that matter is communication to individuals and to the population as a whole. And as an indication of communication, I might note from the outset that here in the scientific community, we have the term modifiable cancer risk factors, but the community would simply understand that same term as meaning the causes of cancer. And when it comes to the causes of cancer, we must acknowledge that we can't identify all of them. This particular diagram on the left indicates what the author calls intrinsic risk factors. These are sharply distinguished from modifiable risk factors and mechanistically involve random intrinsic DNA replication errors. That's the scientific terminology, but even in the scientific literature, that same expression is equated with bad luck. And that explains a proportion of tumours that are called sporadic or spontaneous disease that simply arise, if you like, as background, over the top of which we have the impact of modifiable risk factors. But on the right-hand side of the slide, it's only a certain of those modifiable risk factors that can be identified as defined causes, and it's a subset of those that become the vehicle for prevention. And the proportions here vary dramatically with cancer types. Again, Professor Hunter indicated that that is true, but this is another way of expressing it. In this slide, effectively, the proportion of cancer attributable to modifiable risk factors is shown for the different cancer types. And amazingly, we go from 100% to virtually zero. At the highest level, we know that cervical cancer is entirely caused by human papillomavirus. Melanoma, again, as David mentioned, is effectively all caused, something like 90%, caused by UV radiation or sunlight. But as we go down the slide, the proportion of modifiable risk factors accounting for the incidence of disease decreases. As David specifically mentioned, breast cancer is down to something like 30% of all cases. And when we get to the bottom, we have 4% for ovary. And this slide doesn't indicate brain cancer. But if brain cancer was on the slide, in all probability, the figure for modifiable risk factors would be zero. But in terms of those risk factors, how do we rank them or how do we organise them if we're going to look at cancer prevention? On the one hand, we can look at the magnitude of the risk factors, and in an article by Dr. Kolditz from Harvard, the magnitude of risk factors, as you can see, varies from something like 1 up to 7 or more, which is said to be very strong. So on this scale, tobacco smoking, which has relative risk factors of the order of 20-fold or more, would be very strong. But something like obesity, which has typically risk factors of less than 3.0, would be far less down the scale. However, in terms of the strength of evidence, the confidence that we know about these associations, as exemplified by the IARC monograph evaluations, essentially consumption of processed meat, which is has perhaps a relatively weak association, is as strong as tobacco. Now, because the strength of evidence that both tobacco smoking and the consumption of processed meat contribute to increased risk of cancer is approximately equal. Obviously, this sort of comparison is true of the scientific evidence, but presents a daunting problem when the community tries to understand what the scientific community is talking about. And finally, we can look at mechanisms of association. And some of the modifiable risk factors involve chemical, physical, and biological agents, exemplified by, say, benzene, benzene, UV radiation, ultraviolet light, and human papillomavirus. And all of these things can be classified as carcinogens. And characteristically, prevention achieved by assuming there's absolutely no safe dose, that there may be warning labels and legislated exposure levels, and that in essence, if you cease exposure to these things, it is certain that incidence will be decreased. However, when it comes to dietary related risk factors, those sorts of concepts are virtually useless. We have a much more difficult situation to explain, though the impact in terms of cancer causation is as clear as it is for the known carcinogens. We have experimental evidence that dietary factors may be utilised for cancer prevention, but at the second bullet point, the author of this article, that is Main et al., point out that the studies by epidemiology and by intervention have great difficulty in establishing exactly how dietary composition and dietary factors interact with one another, or as specific agents mediate increased risk of cancer. And effectively communicating this information to the community at large presents a much greater challenge than simple evidence such as don't go near tobacco smoke and never be exposed to asbestos. So we have a communication problem. The risk factors involving diet and obesity are vital to cancer prevention, but the outcomes are largely dependent on personal commitment rather than any legislation to control exposure. Certainly when it comes to processed meat and red meat, we have clear evidence of cancer causation or probable cancer causation. But in the case of red meat in particular, the epidemiology is not absolutely definitive, and the mechanistic evidence of what's going on in terms summarized here as mutation of particular key genes, the APC gene, and the effect of consumption of processed meat on modified bases in DNA, mediated most certainly by nitroso compounds, is noted, and the fact that cooked meat will contain or does contain carcinogens such as heterocyclic aromatic amines and polycyclic aromatic hydrocarbons, albeit at very low levels. But nonetheless, these explain how the consumption of red meat and processed meat contributes to increased risk of cancer independent of obesity. All of the relevant studies are controlled by obesity, but these particular risk factors can be identified in a way that's different to how we identify sugar-sweetened drinks and cancer. There's no question, as summarised by the Australian study referred to here, that consumption of sugar-sweetened drinks contributes to increased incidence of cancer. In this particular study, there was a direct there was a direct contrast between the intake of sugar-sweetened drinks versus the intake of artificially sweetened drinks, and the latter, that is artificially sweetened drinks, did not contribute to any obesity-related cancers, but certainly the consumption of sugar-sweetened drinks did so. Now, there is pressure to try and reduce the exposure, particularly of young people, to sugar-sweetened drinks, But of course, we're dealing here not with a carcinogen and not with an agent that actually can be shown to cause cancer in the way I described for red meat, but nonetheless, the outcome, the bottom line, is the same: increased risk of cancer and the opportunity for cancer prevention if the information is conveyed in a meaningful way. Certainly, there are a range of cancers, as summarised in this slide, that we know are associated with obesity. In this particular slide, in the left-hand axis, we have the strength of scientific evidence in terms of either sufficient or limited. And across the top of the slide, we have the magnitude of risk. And its greatest for endometrial cancer, effectively, at the moment, the only cancer that we know, at least in one study, can be reversed in incidence or decreased in incidence as a result of a conscientious dietary change leading to reduced obesity. That's a big challenge in respect of all the other cancers. Certainly, we know that increased incidence occurs with obesity. What we don't know is whether dietary change and modification of obesity status leads to a decreased risk. The challenge of converting this into cancer prevention is very real indeed. So there are a range of risk factors that we know contribute to increased risk of cancer, which can't be equated with things like tobacco smoke or asbestos in terms of community understanding of how they cause cancer. And dietary composition, body mass index, body fatness, obesity, lack of physical exercise, and sedentary behaviour, to group different parameters that have been studied, all assuredly represent the causation of cancer, but the manner in which these things can be translated into cancer prevention is another thing altogether. And certainly not all the risk factors of this type are not limited to obesity and related matters. Shift work, for example, is probably associated or probably causes breast cancer in women, but the mechanism that shift work does cause cancer doesn't involve exposure to a carcinogen, which would just allow us rapidly to intervene to reduce that risk. Now, the scope of risk factors that are associated with cancer goes way beyond the things that I've just mentioned. This slide shows a section in the current edition of World Cancer Report that was new in respect of all other earlier editions of World Cancer Report in the 2020 edition. And as you can see, it concerns inequalities, what in much of the American cancer research literature is called disparities. And inequalities are identified here not in terms of the fact that they're associated with increased incidence of cancer, but rather, as the section says, inequalities can affect cancer, can be the means of addressing cancer prevention. Inequalities in cancer are something that transcends the normal spectrum between low-income countries and high-income countries, such as those of Western Europe and the United States, the low-income countries being readily identified. But in all of those countries, whether it's sub-Saharan Africa or whether it's the United States, within each country, there are assuredly sections of the community that are disadvantaged, and that disadvantage inexorably leads, amongst other things, to increased risk of cancer. This, of course, we always begin with tobacco, the major known cause of cancer, and this slide specifically indicates what some in the audience have never seen, thank heavens. That is an advertisement for cigarettes. The horses at the full gallop are followed by a gentleman who is managing to smoke a cigarette clutched between the teeth at the full gallop. And I've deliberately obscured the brand names to indicate not so much that smoking causes cancer, which we obviously know, but in this 2021 study, the factor that differentiated cancer incidence according to education. As you can see, I hope in the bottom line, in relation to that difference between cancer incidence in highly educated people and cancer incidence in lowly educated people, the difference was mainly due to lung cancer. And obviously, and certainly, the fact that difference occurred in relation to education status was because smoking itself in most countries is more likely to occur in communities at social disadvantage compared to the higher echelons of the community. Likewise, in a more complicated scenario, that is the causation of colorectal cancer, in this study from the United States, on the left, you can see that the incidence of colorectal cancer in both men and women of African American descent is far higher than the incidence in non-Hispanic white Americans. So without being able to define the exact factors mediating this, we know that disparity according to race and ethnic background also identifies difference in cancer incidence. And going, as David mentioned, to air pollution, this is a slide which at first glance is nothing new. You would expect the amount of air pollutants here, particulate matter of 2.5 microns, would be much lower in rural China to the west or left of the slide than it is in the industrial heart of China on the right-hand side. But this was not a slide in which the investigators were primarily concerned with the difference between rural and urban life. As you can see from the text, their concern was to examine how the difference in atmospheric pollution was correlated with lower socioeconomic status. And the answer was, and the difference in the scale I might add on the right-hand side is over 100-fold. And that this difference is correlated with lower economic and lower education in respect of the communities affected. So a cause of lung cancer by atmospheric pollution is not only worse for those who are in an urban situation, it's worse for those who have lower socioeconomic situation. The situation is not simple. This is a slide indicating the impact of financial hardship in the United States on cancer screening. Now, strictly speaking, this webinar is debated to primary cancer prevention and cancer screening is secondary prevention, but the principle warrants discussion here. That is to say, financial hardship impacts on a complex way. There's not a simple scenario, but factors including psychosocial pressure determine the extent to which members of the American community participate in breast, colorectal, and cervical cancer screening. So financial status impacts on cancer incidence. Now, there's two ways in which cancer prevention may address risk factors related to socioeconomic status. The classic approach is to, and what I've called the focused response here, is to design cancer preventive programs that actually reach communities that are otherwise disadvantaged by financial, educational, racial, ethnic, poverty, or other constraints, and to deliver preventive programs and preventive information to those communities in a form that they can understand and appreciate. But the more comprehensive approach is to eliminate the factors that account for the social disadvantage. And if you do that, then you not only reduce the risk of cancer, but you reduce the risk of all of those, that spectrum of non-communicable diseases, heart disease, respiratory disease, and diabetes in particular. And this slide, which I won't go into in any detail, summarizes them. First of all, is old history. We're talking here about a 2002 publication. So this is not new insight. But 20 years and decades ago, it was appreciated that if there was intervention to reduce the impact of socio-economic inequality, then that impact would come through in terms of the right-hand side of the slide, health status. There's no mention of cancer on this slide. The crucial consideration is that all health is improved if the causes of socio-economic disadvantage are mediated or eliminated entirely. Now, I want to finally mention, in respect of the challenge of implementing preventive measures, behaviour. Behaviour is a complex consideration, seen by some as the outcome of capability, motivation and opportunity. And changing behaviour has been identified with primary cancer prevention, changing so-called lifestyle choices, whether a person chooses to smoke, consume alcohol, to exercise or not exercise, and so on. So behaviour, changing behaviour has always been seen as a critical factor in cancer prevention. But the contrast I want to make, shown in the second bullet point, is that in many instances, human behaviour in our societies mediates directly against cancer causation. Mediates directly against cancer prevention. I won't go into this in detail, except to say it's an ancient slide in which a young person, and you can see that it's decades old, says that smoking is being cool. And clearly peer pressure contributes to people, particularly young people, taking up smoking. And in respect of this particular demonstration of lunch, you could not imagine one person saying, gee whiz, can I have a Caesar salad and some mineral water, unless everyone in the group decided that this was, and I don't want to say the cool thing to do, but the acceptable thing to do. Likewise, this is a hairless mouse, and in hairless mice, the application of sunscreen will totally prevent sunlight-induced or UV-induced skin cancer. These are not hairless mice. Now, it'd be reckless to say I've studied this slide carefully, but you can see that deliberate sun exposure is socially desirable. And indeed, a 2021 survey established that 40% of Australian adults actively seek a suntan, clearly challenging advice to prevent skin cancer by avoiding sunlight, strong sunlight, if at all reasonably possible. So there is a challenge. I don't want to finish on a negative note, but this particular slide, this particular diagram, amazingly enough, comes in a journal titled Molecular Oncology, in an article titled Scientific Knowledge for Cancer Prevention. But the author, Dr. Puska, illustrates the individual having to cope with a burden of health factors and cope with that burden in the context of what society believes and what society has done. Unless we can address those particular factors, then we can't fully optimize the modifiable risk factors that we know do provide the basis for cancer prevention. Thank you.
Thank you, Professor Stewart. What a wealth of information on primary prevention, diet, inequalities, barrier of cancer prevention, a whole incredible amount of information in such a short time. So thank you to both speakers, and we'll now take the question. We have a question from Dr. Anurup from India, and I'll read it out for you. This is a question for Professor Hunter. The modification of dietary habits and increased physical activity is specifically mentioned. Is the modification of dietary habits and increased physical activity specifically mentioned for any variety of cancer? Or is it applicable for all varieties, I guess all cancer types? And then there's a note that says, in Ayurveda, the indigenous system of India, it is said in Kasyapa Samhita that ahara or diet is the best medicine for any disease. Thank you very much. Do you want me to rephrase the question, or you got the gist for it?
That's fine. So the evidence on diet and cancer is best summarized by the World Cancer Research Foundation. They've issued several reports, and with respect to specific cancers, the evidence is best, as Bernard mentioned, for red and processed meat, and the role of red and processed meat as one of the causes of colorectal cancer, and perhaps some of the other digestive cancers. So the evidence that it's a probable carcinogen, or there are probable carcinogens in red meat and processed meat, tends to apply mainly to colorectal cancer and perhaps some of the other digestive cancers. That's probably the best established risk factor, and there's also quite good evidence that high dairy food consumption, which is often interpreted as high calcium consumption, may reduce risk of colorectal cancer. For most other cancer types, there's not a well-established role of diet, but pretty much all of the recommendations for diet and cancer stress that the most healthy diet is mainly a plant-based diet, and red meat and processed meat should be eaten, if at all, in moderation. And the recommendations for plant-based diet are partly built around less definitive evidence for some cancers, and partly because that diet is associated with lower risk of heart disease, stroke, and other non-communicable diseases. There's one other role of diet, obviously, which is the role of diet in obesity. And as Bernard pointed out, obesity is growing as a cancer risk factor for many different types of cancer. And so it's clear that sugar-sweetened beverages, fast foods are associated with obesity. And so reduction in anything that causes obesity is going to reduce risk of many cancers, and obesity is sort of the intermediate factor. Increased physical activity is also usually recommended as a means of limiting weight gain. So the connection of diet with obesity is sort of broad, but focused on limiting fast food and sugar-sweetened beverages. The specific relations with cancer are more about red and processed meat. I hope that answers the question.
Thank you very much. Thank you. I don't see any other questions in the... yeah, here's another question. Let me first read it out, and then I'll see who should address this best. Is there evidence regarding reduced mental or emotional health as a risk factor for any cancer? And I think, Professor Hunter, that question is for you too.
So that's a great question. The evidence are, well, as Bernard pointed out, there are clear socioeconomic disparities in risk of cancer. Some of those may relate to causes of cancer. Many of them may relate to higher risk factor prevalence and exposure to those causes. And many of them may relate to lack of access to things like cancer screening and higher death rates due to lack of access to the best treatments. So to the extent that there is more stress among people who are lower SES and who live more difficult lives, there is that sort of association, but there's no good evidence that it's actually the stress itself that's causing the cancer. It could just be a correlated factor. Studies of when you ask people about stress in their lives, when you ask people about their relative happiness, most of those studies have not seen a relationship with any particular type of cancer. There is also another body of evidence that among people who have cancer is mindfulness, relaxation, stress reduction associated with lower risk of death from that cancer. And there are positive studies there and negative studies. The one thing we need always to be very careful about when we're talking about risk factors for mortality is never to blame people who die from cancer that they didn't fight hard enough or they didn't do enough mindfulness. Unfortunately, once cancer is diagnosed, it can have its own trajectory that it's difficult to intervene on. So again, that literature on stress reduction as a means of improving prognosis is very, very mixed. On the other hand, people in those studies do report higher quality of life, if not longer quantity of life, if they have the ability to do group therapy, individual therapy, other therapies that make the process of being treated for cancer less stressful and less toxic. So again, I hope that answers the question. There's actually no great evidence for stress and psychosocial attitudes independent of socioeconomic status on causes of cancer, and the stress reduction as a means to treat cancer is mainly a factor of increasing quality of life, not necessarily extending life. But of course, quality of life is a very important thing in people who are undergoing cancer treatment and worrying about their prognosis.
I would like to again make another comment in relation to that matter. Certainly David has indicated the complex field very adequately, but I'll refer to a study I did with Freddie Sitas and Simon Wilcox, which surveyed 4,000 cancer patients and asked them to state what they thought caused their cancer. Roughly 2,000 said they had no idea. But of the 2,000 that did state what they thought caused their cancer, an overwhelming majority stated that their cancer was caused by stress. So there is a community perception in relation to stress that simply doesn't match the available scientific data. I think that the committee recommending priorities for IARC monographs have coped with the possible evaluation of stress. So it remains a real problem. But as David says, the evidence is very poor, but in terms of community perceptions, in terms of what the community will do to adopt preventive measures that actually work, there is awareness of stress that is quite unrelated to the body of scientific evidence.
Thank you. Thank you very much. This is a very detailed, helpful answer. We are about 2 minutes after the hour. I think we have some more very interesting questions to answer. So if you can stay on the line for another 10 or 15 minutes, that would be wonderful. Is that okay for you?
That's okay.
Great. Thank you so much. So I have here another question regarding communication with decision makers. How can we improve communication with decision makers, particularly about the impact of life factors? And I was going to let Bernard Stewart answer that question.
I think communication with decision makers, and particularly I'll say government and regulators, is challenging, and in many societies has to be in competition with a whole wealth of matters that are being brought to their attention as desirable aspects for action. So I think it's up to the medico-scientific community to advocate as clearly as possible in respect of what I would call proven measures to reduce cancer incidence. That said, whereas some measures have been communicated with great success, and the fact that the Australian government banned cigarette packaging that named the maker, and actually by law, cigarettes in Australia are sold in an olive green pack that simply states the maker's name in a simple font and is covered 2/3 with health warnings. That's an indication of successful communication with regulatory authorities. But in respect of, say, discouraging the consumption of sugar-sweetened beverages, we have a great challenge, and much of the response is not to doubt the science, but to say regulatory intervention on this matter involves some sort of nanny state attitude, and it should be up to the individual to decide for themselves what the evidence indicates and what actions they should take. And we, the powers that regulate, want nothing to do with it.
Thank you. Great. I have another question, actually two questions that we could combine about physical activity and obesity. What proportion of cancers are due to obesity in LMICs? And is there evidence on physical activity effect on cancer independently of obesity?
So let me take that on.
Okay, that's fine. Sure.
So it's not clear whether physical activity has a beneficial effect independent of obesity. It probably does a little bit, but the clearest message is that prevention of obesity does prevent a wide variety of cancers, and physical activity is an important means of reducing obesity. The question about what proportion of cancers in low and middle income countries is due to obesity. Right now, it's modest, particularly in countries where the most common causes of cancer are stomach, liver, cervical, associated with infections. But it will grow as the obesity-related cancers, which we see in developed countries, become more common in less developed countries as they move up the Human Development Index. So the cancers that are most strongly associated with obesity, endometrial cancer in women, postmenopausal breast cancer, we think we know why, because obesity, fat mass increases the amount of estrogen in the bloodstream, and so increases the risk of estrogen positive breast cancer, increases the risk of endometrial cancer. The answer is that right now, the proportion of cancers due to obesity in certainly low income countries is small, but the obesity epidemic is growing rapidly in almost all countries. And so that proportion is almost guaranteed to increase over time.
Thank you. Thank you. We have plenty more questions. So I have one a very interesting one here about inequalities. What are your recommendations for the inequalities in access to cancer resources for prevention? For example, Africa has a very low access to cancer resources, yet huge number of new cancer cases is diagnosed in this region, including high mortality rate.
I think the answer to that in terms of recommendations, that is, what should we do in a particular country or in a particular context, is not one that someone like me or anyone else can produce an immediate priority action list. The challenge is so much up to the country concerned, or it's so much, the challenge is to, in relation to a particular country, rather than making generalizations worldwide, as I was forced to do in this webinar. But when it comes down to specific actions, one has to look, so far as I'm aware, at the situation in a particular country, not simply in terms of the inequalities, but also in terms of the resources. There's no point in stating the general principle that if all these bad things were taken away, cancer would be prevented and life would be much better. That's undoubtedly true. But to achieve the reduced inequalities depends critically on the resources available and the priorities adopted specifically by governments and the extent to which action can be taken that will actually make an impact. So it's one thing to bring the cancer preventive programs to the disadvantaged communities. That's often achievable, but to actually remove the cause of the inequalities is a much bigger challenge.
Thank you. And maybe this will link to this other question from India. Can health promotion education in schools change the social influence effect on selecting our health over illness?
It's a big, I would not presume to comment on a specific answer for an Indian context. I apologize, I simply do not know the ramifications. I know in high-income countries like my own, the impact a schooling can make in respect of such things as sun exposure, where all infants, children, let alone any other in this country, wear hats, and where tobacco smoking is made to be not as attractive as it was decades ago as a means of teenage independence. These are scenarios that can be taught in schools, but the way in which they're implemented in India is, I must confess, way beyond my knowledge and expertise.
Professor Hunter, would you have something to, would you have an answer to this question?
So again, I would just echo what Bernard said there about the success story of controlling sun exposure in Australian schools. Shades were put in over playgrounds. Kids are all wearing hats. And in some parts of Australia, the actual school day has been moved so that kids aren't running around in the sun when the sun is at its peak. And these are all things that, as an Australian growing up 50 years ago in Australia, you know, it's quite astonishing, because at that time, the dogma was that you were supposed to get a tan as early as possible in summer and retain it. And now the whole social attitude to sun exposure is completely different, 180 degrees different. And, you know, it's a fascinating study of what actually can be done with behaviors that you think are completely entrenched, socially determined, and non-modifiable. With respect to India, I would just note, as the person asking the question probably knows much better than I, certainly knows much better than I, you know, one of the issues in India is exposure to smokeless tobacco, pan, snuff, and children being exposed to that at a young age. And there's very good evidence that that exposure leads to oral cancer, and someone starting that behavior at age 10 is much more susceptible than somebody starting that behavior at age 25, if they did. Not just because they'll be using those products for a much longer period, but because somebody who's growing is more susceptible than somebody who's completed their growth. And so that really is something where legislation is needed, but also enforcement of legislation, because I understand a lot of these products are available, if not at schools, then immediately outside the school gates. And it's hard for kids to avoid them. And there's focused marketing on children. So that is a major opportunity, but I wouldn't underestimate the difficulty of not just getting the legislators to legislate, but also the people responsible for those regulations to actually enforce them.
Thank you. And in fact, I'd like to take the prerogative of the chair to add some really hot from the press information on that topic. The IR Handbooks program is just reviewing the evidence on oral cancer prevention, both primary and secondary. And in the part that reviews primary prevention, we have evaluated, first of all, whether reducing exposure to the risk factors reduces incidence of cancer mortality of the oral cavity. And we have also analyzed the data on the interventions to reduce the consumption, in fact, to quitting, because we cannot really talk about reducing prevalence. There are quite some studies among adults and among adolescents about interventions also in school to prevent, either to prevent initiating or to help quitting, and without selling the response. I can say that the information is quite promising in terms of the effect of these interventions. So I think overall it's quite promising. Great. We have another few minutes if you are happy to stay on. There is one actually for specifically for the second speaker. So Professor Stewart mentioned sexual activities as one of the factors of preventing cancer. May he please explain how and what types of cancer can sexual activities reduce?
Sexual activity is a polite way of indicating a risk factor for cervical cancer specifically. It's not a matter of it's not the key means of preventing cervical cancer. Cervical cancer is most successfully prevented, firstly by screening, and secondly, most comprehensively, by vaccination. The fact that multiple sexual partners increases risk of cervical cancer is an example of a risk factor determined by behaviour, and that's why I was including it. But it's not the vehicle to prevention, as I mentioned, thankfully, because the infectious agent that accounts for that particular observation, that is sexual activity, is a virus, and the virus is the means through which vaccination is successful. So fortunately, we stand on the brink, at least in some countries, specifically including Australia, of eliminating cervical cancer without having to focus on sexual activity as a preventive option. Thank you.
Thank you. So we have one person who reacted on the discussion about UV light and sunscreens. And the question is whether people with a darker skin need sunscreen, not necessarily of black ethnicity, but maybe of Indian skin tone, whether they need sunscreen to prevent sun exposure.
The situation is susceptibility to sunlight-induced skin cancer varies markedly with racial orientation and genetic makeup. The Celtic complexion of red hair and blue eyes is the most susceptible, and olive skin, amongst white races, olive skin is relatively resistant to sunlight-induced skin cancer, and amongst black people, if I can use that term, such skin cancer is almost unknown. So genetic makeup and your skin type absolutely determines susceptibility, and therefore the sunscreen is most effective in respect of the most vulnerable population, the white skin, red hair and freckles scenario, and is less important for people with olive skin and who are, fortunately for them, more resistant and less susceptible to UV-induced carcinogenesis.
Thank you. Thank you. I will take one last question. This is probably for Professor Hunter. The question was about, what about liver cancer? So the non-alcoholic FLD, I don't remember exactly now, and NASH pandemic concerns every 5 people in Europe and is a cause for liver cancer. So how can we, I guess the question is really how to prevent liver cancer.
Right, that's a very good point. You know, we used to think that liver cancer was almost entirely due to hepatitis B, hepatitis C, and the toxin aflatoxin. And that was largely the case in the areas of the world where liver cancer incidence was higher, and it's still the case in those areas. But as we've seen the obesity epidemic accelerate in developed countries, we're seeing more liver cancer than we should on the basis of the vaccination against hepatitis B and potentially the elimination of hepatitis C. And that appears to be due to the fact that in obese people, a liver that is fatty is a liver that is being injured and more likely to develop liver cancer in the absence of high alcohol intake, in the absence of the infectious causes. So that is unfortunately a obesity attributable component of liver cancer in largely developed countries, and another reason why avoidance of obesity is critical to reduction of cancer burden.
Thank you. And I think we have now covered all the questions, and I'm really happy that you were able to answer all questions live, because it really makes for the whole purpose of the webinar is really to hear the response from the expert rather than having to read it in a chat box in your own office or living room, wherever you are. So this is for me at the end. I really want to thank our both speakers, Professor Bernard Stewart and Professor David Hunter, for this really enlightening presentation and very thorough response to the questions. It was a pleasure to meet you again through this occasion. And I wish you all a very good day, night, and evening.